Welcome everyone. This is Patricia from the International Hospital Federation. I hope you're all safe and in good health, and thank you for joining us today. Managing the complex and rapidly evolving COVID-19 has been extremely challenging for hospitals and health systems around the world. The IHF is hosting this webinar and live Q&A series to share experiences, good practices, and lessons learned from our members and other organizations. I would now like to introduce the moderator of this webinar, IHF CEO, Eric Derdenbeck. Eric?
Thank you, Patricia. Welcome to this session where we'll hear from the situation and solutions adopted in Korea, especially the 4 T's, T like tango, strategy. In this webinar, we want to insist on the approach from the perspective of the leaders of health facilities having directly to deal with COVID-19. What actions were taken at the level of facilities versus implementing national recommendation? What has been successful, but also what has been very challenging from the perspective from healthcare leaders? I want to insist on the fact that the Q&A will focus on the broader management and leadership perspective, but we can't really take any specific question related to clinical issues. The objective of this webinar is really to share experiences that can help you in charge of healthcare organization in making decisions in your own facilities and avoiding taking a path that might be of limited chance of success. Now let me introduce you to today's speaker, Dr. Wang-jun Lee, CEO and Chairman of Myongji Hospital, Myongji Medical Foundation, South Korea. Dr. Lee is Chairman and CEO of these organizations, including 2 acute hospitals and 3 long-term facilities. But he is also a CEO and Chairman of startups like biotech company, Cancer Rope, that is listed in COSTAC, or cell therapy company like MJ Cellbio. He is also the executive chairman of the International Affairs of the Korean Hospital Association. The Korean Hospital Association is a member of IHF, the International Hospital Federation. And under this responsibility, he is also the General Secretary of the annual Korean Healthcare Congress. Dr. Lee, he has graduated from Seoul National University College of Medicine, where he achieved the Board of Surgery, and he was awarded a PhD degree from the same university. Let me welcome Dr. Lee. The floor is yours, and we are very eager to hear from your organization and your country.
Thank you for your kind introduction. Hello, everyone. I'm Dr. Wang-jun Lee, the chairman of the Myongji Hospital and the General Secretary of COVID-19 Emergency Response Committee of Korean Hospital Association, and a member of the Advisory Board of Korean CDC. It is a great pleasure to meet all of you, and I'm really happy to share our experience with you from all over the world. I will present the experience of COVID-19 in Korea and the Myongji Hospital, especially what are the distinctive characteristics of Korean situation. The title is Trace, Test, Triage, and Treat COVID-19 in Korea. In Korea, the first confirmed case of COVID-19 was reported on January 20th, 2020. This bar chart shows the trend of April 6th. The total confirmed patients are almost more than 10,000. Among them, around 6,600 were discharged after recovery, and 186 died. So until now, fully recovered patients percentage is 64%, and mortality rate is 1.8%. As you can see, this chart shows the epidemiological curve in Korea, and it has three distinctive phases. Now we are in phase 3, where we have seen a downward trend in new cases with sporadic new clusters of infection. I want to separate the epidemic curves according to two types of spreads. One is that Daegu and North Gyeongsang province area, where the primary outbreak was caused by Shincheonji Church, or a certain religious group. At that time, that was more than 85% of the total confirmed cases. As of now, it accounts for around 50% of the total confirmed cases. As you can see, the green curve, the outbreak of this area has been subsided totally. The other epidemiologic curve, the red curve, shows the Seoul metropolitan area, including Gyeonggi province and Incheon metropolitan city. This area contains 25 million of population, or half of entire Korea. I want to emphasize at this point, the number of population in Daegu and North Gyeongsang province area is only 2.5 million, 1/10 of the metropolitan area. So that was a major outbreak. Korea displays epidemiological characteristics different from China, as more women than men were infected with COVID-19. And the largest affected group is in their 20s. This is very unique statistics because of the Shincheonji Church. The most of the 20s were the worshippers of this church. The next highest number is in their 50s. This age group would be more vulnerable to this virus. Similar to China, Korea also witnessed that fatality increased with age, and that the mortality rate is around 20% for in their 80s. Geographical epidemiology of COVID-19 is as shown. As you can see, mainly in the Daegu and North Gyeongsang province area. From now on, I would like to summarize the 4 characteristics of strategies to fight against COVID-19 in Korea. The first strategy is transparency and openness in communication. Not only the Korean government and Korean CDC, but also all the media and institutional stakeholders share all the information about COVID-19 simultaneously. Moreover, the Korean CDC provides all the information of the confirmed patients daily basis, such as where, when, with whom he or she moved, stayed, or contacted, and so forth. For the reason, we did not experience any confusion or doubtful worries, unlike the MERS outbreak back in 2015 in Korea. That was the very dramatically changed manner of the government as well as the public. Also in Korea, we did not lock down any cities, even Daegu and North Gyeongsang province area during the most peak of the outbreak. We did not close or lock down any airports either. The international entry has been opened from the beginning of the outbreak till now. The second strategy is that we combined 2 track strategies, the containment policy and the mitigation policy. As you know, the containment policy means to find out the infected patients immediately and isolate them and block the secondary and tertiary transmission. Of course, we have started this containment policy just after the first infection in China last December, so that we can track all suspected cases and trace all the confirmed cases. Mitigation policy, also known as social distancing, was introduced to low down the peak of outbreak in order to maintain within our capacity. We started this mitigation policy combined with the containment just after the big outbreak in Daegu and North Gyeongsang province area. We started the social distancing campaign and decided to close all the schools, recommended to avoid any gatherings and work at home and so on. But all these policies were voluntarily followed by citizens rather than forcible or suppressive manner. We are so proud of this promotive participation of the citizens. Third strategy is the triage and treatment system. We invented and adopted very creative system in Korea. This way was mainly based on the experience of MERS outbreak back in 2015. As you know, the biggest challenge in an outbreak is overflow of the patients exceeding the capacity of hospital beds. Already we observed this problem in many other countries right now. If the hospital shut down, not only the COVID-19 patients, but also the other severe patients would be more threatened. Our main purpose is how to keep the hospital capacity to care the critical patients. That means hospital focuses to severe and critical status of patients rather than mild and moderate status. Along with big data, 81% is mild and moderate, and 14% is severe, and 5% is critical. Therefore, in Korea, we focus to invent the new triage system. For the 80% in mild to moderate status would be sent to special facilities, so-called community treatment centers. We modify the corporate training centers, dormitories, or resort hotels to transient isolated treatment facilities. We dispatch doctors and nurses to this facility and monitor each isolated patients 4 times a day. These facilities are very comfortable and convenient rather than gymnastic stadiums with the temporary beds. Lately, we have prepared 5,000 beds as for these community treatment centers. And the second tier of the triage is the public community hospitals. We emptied these public community hospitals to receive COVID-19 patients, especially moderate to severe status patients, up to 1,000 beds. And the third tier of the triage is the 29 national designated hospitals for infectious disease equipped with negative pressure isolated units. The other 30 tertiary care hospitals joined to receive critical patients. We have prepared around 500 negative pressure isolated units for critical care. And all the fee for caring COVID-19 is covered by national health insurance and the government. The last strategy is massive screening and fast tracking. I think the successful factor of Korea's situation is mainly based on this. Until now, in the battle of COVID-19, the only weapon is the diagnostic kits. We have no therapeutic drugs or vaccines. The only way is how quickly we can find out the confirmed patients. Korean CDC and Korean biotech companies shared information and raced to develop test kits and made them widely available since early February. Second point of massive screening is fast and quick testing. To ensure that, Korea developed drive-through and walk-through test centers for the detection of COVID-19. The drive-through test centers are operated by local governments and medical staff dispatched from local clinics. And they offer tests to local inhabitants, while the walk-through stations are operated by hospitals. The third point is laboratory capacity. Aside from Korean CDC laboratories, Korea has more than 100 hospital laboratories as well as commercial labs working around the clock to test the samples. All in all, the daily testing capacity is around 20,000 samples. And doctors are very free to request because all the tests for suspected patients are covered by national health insurance. As such, preemptive and quick diagnosis testing was crucial in Korea to minimize the COVID-19 casualties. From now on, I want to introduce Myongji Hospital very briefly and why we are so strong against this shocking virus, COVID-19. Myongji Hospital is a training hospital with 700 beds located in Goyang City, very adjacent to Seoul Metropolitan City. We are non-profit private medical foundation, and we became a member of Mayo Clinic Care Network since 2018. We have run wide regional emergency center and level 2 trauma center that covers nearby 2 million residents. And Myongji Hospital was designated by the government as a control hospital for infectious disease and disasters since 2014. We established 12 negative pressure isolated units. Among them, 5 units in ICU, 3 in emergency center, and 4 in general ward. We run a simulation drill for emerging infectious diseases twice a year. For instance, Ebola outbreak or SARS-2 outbreak. Based on these training and preparedness, we successfully responded to MERS outbreak in 2015. At that time, we were very praised by the government and public and got the IHF Grand Award. We started to prepare for this COVID-19 pandemic right after the first patient was reported in China. Since the third patient with COVID-19 in Korea was transferred to our hospital, we started the big battle, not against the virus itself, but the fear and phobia. To maintain the hospital's capacity and control, Myongji Hospital started 2 tiers of separate screening centers. One is emergency department-based screening center, which is focusing more on the high-risk group. For instance, patients with travel history to China or Daegu, or with fever and respiratory symptoms, or any contact history with confirmed patient. In here, we try to isolate the patients immediately who are highly suspicious or take PCR samples for symptomatic patients. The other one is outpatient department-based screening clinic, which is more oriented to simple flu-like illness. This is a sort of fever and respiratory symptom specialized clinic. After a consultation with doctors, some of the patients take the PCR test. This chart shows the flow of the outpatients, how to screen COVID-19. And this building, also known as Block E, is very specially designed for emergency care and infection control. The first floor is the emergency center with 3 negative pressure isolation units and screening centers. And E2 and E5 are all designated for carrying COVID-19 patients. And we changed the general ward E3 into PSU, pneumonia surveillance unit, only to concentrate on the pneumonia patients. Also, we modified under the general ward E4 to ASU, admission screening unit, because we wanted to make sure to check every single hospitalized patient by PCR test before their admission. Only after we confirm the negative results can the patients be moved to the general ward. This is the flow of isolation and de-isolation of confirmed or suspected COVID-19 patients. We want to emphasize that the only important criterion whether to isolate or not is the result of diagnostic PCR test. There are no options to replace it. Fortunately, we can get the result within 6 hours from our in-hospital laboratory. This is the flow of triage on COVID-19 patients. We classify the patients in 4 categories based on severity, which is determined by modified early warning sign score, oxygen saturation and oxygen supplement, and the presence of or absence of pneumonia. Already the whole 12 weeks have passed since we have fought against COVID-19. We have now treated around 34 confirmed patients. So I would like to talk about the clinical experience of COVID-19 patients at Myongji Hospital. Case 1. This patient was the first patient with COVID-19 in Myongji Hospital. 54 years old Korean man living in Wuhan, China, entered to Korea in January 20th. This case was reported at the Journal of Korean Medical Science in detail. Incubation period was 5 days, and the pneumonia developed 8 days after the first symptom. He fully recovered on illness day 17 and discharged to home 2 days later. We gave him empirical antibiotics and antiviral agents. This case shows very typical clinical course of COVID-19. For more detailed information, please refer to Journal of Korean Medical Science. Case 2, the second case, 52 years old female. She was previously healthy. She came with myalgia first and soon got fever and cough. After confirmation for COVID-19, her chest radiography revealed bilateral pneumonia, and she was admitted to Myongji Hospital on illness day 10. The day after admission, she got worsened immediately, so we intubated her for mechanical ventilation support. Fortunately, 7 days later, her conditions improved and ventilator was successfully removed. The patient was discharged home after rehabilitation in the general ward after releasing quarantine. K3, the third case is the most severe patient. He is healthy 58-year-old man and had no underlying disease. After confirmed in PCR test, he was admitted in community hospital. On illness day 15, he was deteriorated. He was transferred to our hospital and had respiratory arrest. We intubated him for mechanical ventilation, and we also had to insert VV ECMO in order to maintain sufficient oxygenation. Unit ECMO, the extracorporeal membrane oxygenation. After 10 days of the intensive care, we were able to taper off the ECMO, and the patient is recovering from the respiratory failure. As we obtained in case 2 and 3, the patients worsened while the viral titer was decreased. So we assume that the hyperinflammatory status during virus clearance would be the reason for the clinical deterioration. We can see the clinical course based on our hospital's cases. It is average days of exposure, onset of symptoms, isolation, and release from the quarantine is consequence of negative test result. Aside from treating patients, we have done many things to overcome this situation. I just would like to share 4 more things. First, as I mentioned before, we have reported patient number 3 with details. This first case was caused tertiary transmission in Korea. It is the first case of outside of China. The second is the COVID-19 RT-PCR diagnostic kit that we developed in partnership with biotech company CancerRob, a subsidiary of Myongji Hospital. We have obtained the Korean FDA's approval for export and are submitting US FDA's emergency use approval. The third one is that we are collaborating with a company specializing in artificial intelligence solution to diagnose COVID-19 using chest CT. The last one is psychological support for the patients. As you know, the isolated situation itself is very desperate and deteriorate. Most patients need both psychiatric consulting and psychological help. That is why we organized the Bedside consult to support the patients hosted by our Art Healing Center. You can also watch video clips on YouTube. This is all I want to share with you today. Thank you for your attention, and I expect your good comments and questions. Thank you so much.
Thank you so much, Dr. Lee. And this is very impressive. Very impressive result. I would say if the situation was not so dramatic, I would want to clap when I see such an impressive result. I'm sure that we'll have a number of questions from the participants. But as you know, I'm coming from not from a clinical background, but more from a general management and leadership background. So I wanted to ask you a question about, how much the organization that you have put in place, even if it was done early and not in a panic or in a rush, made differences in the way your governance of the hospital is set up? Did you have disruption in the way you are organized to make decisions because of the COVID? Or did you carry on all the decisions and the activity within the existing processes that are in place in the hospital?
So the Korean situation is a little bit different to other countries, very characteristic, because in 2015, we experienced MERS outbreak. Middle East respiratory syndrome. The outbreak was really fatal to Korea because at the time, that outbreak was only in Korea, just outside of the Middle East. And at the time, the totally infected patients was up to 2,000, and around the mortality was 20%. Around 40 patients was passed away, sacrificed. So we experienced the MERS outbreak for nearly 4 months at the time. And even the Samsung Medical Center, the biggest and the best hospital, was also deteriorated by that MERS virus. Even the Samsung Medical Center was shut down for 1 month. So every hospitals really experienced that very crucial condition of outbreak. So after the MERS experience, not only the Korean government and Korean CDC, but every hospital started to prepare to be ready for this new infectious disease outbreak. At that time, as you know, the Myongji Hospital was on the front of the MERS outbreak, and we received several patients from the other infected hospital, and we treated very successfully. But not only such case of my hospital, but the other hospitals were very keen to be ready to this new infectious disease. So just after the first patient in Korea, the first patient in Korea was January 20th. As you know that the first reported patient in China was the last day of December. So 20 days later to the first report in China. So just after the first confirmed case in Korea, January 20th, just I think within a week, even the more than 500 hospitals established the screening centers just outside of the emergency centers in every hospital. So 500 hospitals, of course, that would be nearly all the general hospitals. They voluntarily established the screening centers, and they started the same manual how to screen the virus suspected patients. Because we did not fully well known about this new virus, novel coronavirus. But anyway, this virus is also the same virus, very similar, different type of the virus as for the MERS and also SARS virus. So that was, I think, the main reason the Korea could be very successfully and very rapidly respond to this outbreak. So until now, we confirmed more than 10,000 confirmed COVID-19 patients, but the mortality is rather around 200. So nearly 2.1%. So just around only 2% is, I think, good results because we responded very rapidly.
Okay.
And yes, yeah.
Yeah, thank you very much, Dr. Lee. So we really understood that, you know, the organization was so well in place and so early that you were able to face it without major disruption or changes. There are many questions. And so if we can have short responses to these questions.
Okay,
so
yes.
One is coming from the lack of personal protective equipment. Many countries are facing that. Have you had any major problem for personal protective equipment in your responses in Korea?
So as for the the government designated control hospital for infectious disease were already very well equipped with the PPE and other equipment or any supplies. So we were not short of any PPE. And also the general hospitals, they also started to prepare all the PPE just after the first confirmed patient. The only problem was that the Daegu and the North Gyeongsang province area, there was very similar to the Wuhan and Hubei area in China, because at the time 80% was all concentrated in that small areas. So at the time, we shared all the supplies to those areas, and we sent and we concentrated in those areas. So at the time, there was very hardly sustained, but we did not experience the actual shortage of the PPE or any supplies, because that outbreak was only just a focused outbreak in one region, but the other areas, very fortunately, not so rapidly spread.
Okay. So the solidarity in between the healthcare facilities have avoided a shortage in places that were more under pressure. Another question, which is, with the COVID patient, does it had any impact on the management of the healthcare waste? Did you have a large volume of waste to manage, and that did it generate any problems or any specific responses? The waste is what is especially with the PPE, which is a lot of single-use devices.
Okay, the waste after the usage of the PPE, they are all controlled by the central government. So already all the hospitals are contracted to very special agency to dealing with this waste of the hospital used the materials. But in this time, we did not experience such like the bottleneck of the treatment of the waste. There was also only some burden, a big burden in Daegu and North Gyeongsang province. So for around 3 weeks or 4 weeks, there was a very tense burden. But after then, everything was not so big stress. And only one a little bit confusion was to share the masks to the whole public. So the capacity, the daily production of masks in Korea is 15 million masks per day. But the population is 50 million. So the government determined to distribute 2 masks per week for each people. So there is a public distribution to all the people of Korean nation. So 1 week or 2 weeks were a little bit confused, but after that, this distribution of daily mask was also very stabilized. So no confusion right now.
Thank you very much. We need to have short responses, Dr. Lee, because so many questions. There
Okay.
is a question that is also happening in many countries. While you are dealing with COVID patients, what happens with the other ones? Were you obliged to postpone some of the care? Were some patients diverted to other kind of facilities? Did you have longer waiting line? Have you been able to handle all your patients as business as usual or not?
So for the reason we designated some public hospitals to empty, because the public community hospitals were focused to only COVID-19 patients. Besides that, public community hospitals, all the other general hospitals are dealing with the two tracks of patient care. So COVID-19 patients focused track is also accompanied with the normal process. Of course, a little bit delay for the ordinary people, ordinary patients, because any other ordinary patients who has some symptoms like a fever or respiratory symptoms, they should be checked for COVID-19 PCR test. So for this test time, they should wait for next process. Besides that, we try to keep the normal process of the hospital patient care.
Okay, thank you very much. Two questions. One is on the role of the Korean Hospital Association. What specific role has the Korean Hospital Association played in the COVID-19 response strategy in your country?
Yes, and as I introduced myself, firstly, we immediately organized the COVID-19 Emergency Response Committee in Korean Hospital Association. I'm the General Secretary of this committee. And we are running until now the headquarters office of this Emergency Response Committee to gather all the information from the hospitals. And we are not in front of the battle, because the front headquarters is Korean CDC and the government, but we are the very influential and very strong advisor to the government and CDC to coordinate the policy, and also we always transfer the actual problems from the hospital base to the central headquarters.
Okay, yeah, thank you very much. Other question is about, we've seen what has been successful. Is there anything that did not work as expected, that if you had to do it again, you would do it differently? Because that's also a very important learning for people, to learn from, what has not worked so well, and so that they don't make the same mistake.
So I think that we experienced a little bit similar, but very distinctive to the MERS outbreak experience, because in Daegu and North Gyeongsang province area, that outbreak was never expected, unexpected outbreak, because of the Shincheonji, the very special certain religious group. So we did not expect it. So there was very suddenly outbreak. So at the time, even the local government or Korean CDC could not establish the real triage system. So we suggested a new triage system, but for first 2 weeks, that triage policy was not activated. So a little bit confusion. And for the during first 2 weeks, some patients were died at home, not treated in hospital. But after 2 weeks, as I mentioned, the triage system was worked, and then the confusion was disappeared. So you know that the mild and moderate to severe and the critical, the 3 tiers of triage system was very important. So I think in next time we will develop more well-organized triage system.
Okay, thank you very much. This is also a very important lesson. Another question related to the policy with the health professionals in related to communicating with media, including social media, because this is a new virus. There is a lot of uncertainty. And so if the communication goes all over the place, then this is bringing more confusion. So have you in place specific rules and recommendations for the health professionals about their public communication around the virus and the interventions?
Yes, and beginning from the beginning, the Korean Hospitals Association recommended to government to organize a very special committee, so-called Nationwide Commission for Clinical Decision. So it's like a clinical headquarters, supreme headquarters committee, and then we organize the specialists in these more professional committees to discuss about the real characteristics and the clinical courses of the virus infection, and then we can control the opinion rather than the very individual or very confused information. So always this central commission, the nationwide central commission, they had a weekly briefing to the public and to the media, and then the Korean CDC received this opinion and they reflected to their policy.
So importance of having a very clear communications channel that is well aligned. A last questions, because the time is dragging out, many questions as usual, but I have to make some selection. One that is coming also very often is around, you know, how much the taking care of the COVID patient has required to change the way physically, you know, the hospital are organized. So how much the hospital has to reorganize their wards, redistribute their activities. And I guess you didn't have to build any, as you said, any hospitals. You could totally reuse the existing facilities.
It is a little bit tricky because as I presented, 29 hospitals were designated as the control hospital for the infectious disease, and the other hospitals are not designated. But after the MERS outbreak in 2015, every hospitals should equip negative pressure isolation units for infectious disease were mandatory. So bigger than 300 beds general hospital, they should equip this special negative pressure isolation units, and for instance, it's 100 beds per one isolation units. So if that would be 900 beds, maybe there would be at least 7 or 8 isolation units for the infectious disease. So this is in the aspect of hardware, we were all prepared. So I expect after this COVID-19 outbreak, and we will try to more equip more for the hardware. And also we equipped more ventilators and ECMO for the critical care after the MERS outbreak. And that was, I think, very helpful for this condition.
Thank you very much, Dr. Lee. And let me wrap up our webinar with some takeaway messages. And I hope I will be I will cover very well what your message is. So if I can say, there is at least with the 4 T's, that's very clear in terms of a national strategy. We need a very clear communication, not to confuse the population, and transparent. We need a very clear containment system for the suspected cases, and we need a very effective triage system that allows the hospitals to distribute and ventilate the people, not with ventilators, but distribute the people in the right places. But also important element at the level of the hospitals is clearly no financial obstacles. As you said, everything was free of access, so nobody was not going to take the care of the test because of financial constraint. The capacity to deliver and treat and early preparation are elements of this success. But also very important is the capacity to share the clinical result very quickly, to work with the startups, and to also put in place this psychological support. You mentioned that this is an important dimension that is not perhaps so much underscored. The people that are going through all this period, they will need a very strong psychological support. If you want to share one concluding message, Dr. Lee, before the closure.
So we are confront to really this centennial infectious disease. So hopefully every nation and every hospitals, every professionals would more strive to defeat this new novel coronavirus. Thank you. Thank you for your attention.
Thank you very much for all your contribution, what you have brought to us. Patricia, you take the floor now.
Thank you very much, Dr. Lee. We also would like to thank everyone who joined us today. Again, the webinar recording will be posted on our website in a few days, and you will be notified via email once it's available. We hope you can all join us again. We have several webinars lined up in the next few weeks. The schedule is on your screen, and you can register on our website. Just go to www.ihf-fih.org/webinars. You will see there that the next one is on Tuesday, 21st of April at 8 UTC. Dr. Norio Omagari will share how the National Center for Global Health and Medicine is managing the COVID-19 response in Japan and the public health interventions to contain the disease. Please keep safe and healthy, everyone. Together, we will overcome this crisis. Thank you again for joining us today. Again, Dr. Lee, the rest of the team at the Korean Hospital Association and Myongji Hospital, we thank you so much for your time and all the contributions and the learnings and information that you shared with us today. Thank you very much.
Thank you.
Thank you. Goodbye, everyone.
Yeah, bye.